Hi, it's Shelly with Shelly's Nursing Review. And so today we're going to look at A-Fib and A-Flutter and look at our first nursing action, causes, symptoms, treatments, and those sort of things. Now, we need to start by understanding that A-Fib and A-Flutter are the most common dysrhythmia of all, right? So you really got to know it. And here's the deal. Watch this. This is really kind of interesting to me. When you look at A-Fib and A-Flutter, not only is it the most common dysrhythmia, as it turns out, 1 in 10 adults over the age of 70 have A-Fib, and 1 in 3 of those will have a stroke as a complication from their A-Fib. So you can only imagine how necessary it is for you to really know A-Fib and A-Flutter. Now, you know what we tell you. We tell you, and we're going to show you, that all you have to do with A-Fib is look at it. Just freaking look at it. That's our famous theme of EKGs. Just freaking look at it. So if you look at it, it's always irregular. Oh, that's going to help tremendously on any test you take. It's always irregular. I put my name on it. I tell you, I swear on the Bible, it's always irregular. Now, the other thing that I think helps a lot is there's no P waves. And you kind of got to remember that the P wave is this cute little hump right before the ziggy-zaggy QRS. That predictable moon, half moon shaped P wave is missing with A-Fib and A-Flutter. Then get this, this is what you care about. The heart rate can go up to 150 to 300 beats per minute. It can be so ridiculous. And as you know, based on the other videos that we've done, you know that a heart rate that high, tachycardia that high, can cause decreased cardiac output because you're not allowing the heart to fill with the blood and effectively pump the blood out. You're just doing crazy on steroids, right? So that's the deal. Now, when we talk about causes, we have a ton of causes, which we're going to come back to. But then when we talk about your first nursing action, it can't get any simpler. You already heard me say with the heart rate that fast, you cannot have adequate cardiac output. So then your number one goal, your highest priority, is to control the rate. We're going to talk about how you do that with my simple A, B, C, D plan. A2 means there's 2 meds. The B and the C and the D, we're going to talk about. Now, the last point today that we're discussing, of course, is if your patient's unstable and they remain symptomatic, then we're going to do a cardioversion after a transesophageal echo following NPO status. Now, this is true also if the A-Fib has been going on for more than a day or 2. So the last thing we cover outside of this cardioversion will include how to take a patient, prevent the number 1 complication of stroke with maintenance medications or procedures that really do the trick. Now, you know anticoagulants because we talked about it last week. You know your NOACs because we talked about it last week. You probably know, because we talked about it last week, amiodarone is a cardioversion medication. You should know ablation because we covered that a few weeks ago. You know that ablation can provide either a microwave type of heat or a cryo-freezing type of action to the area in the heart that's causing the drama. And then you probably know, because it's been on the commercials quite a bit, there is a fascinating new procedure called the Watchman implant device. So we're going to talk about all of that today.